Thank you, Vishal, and thank you, PK, for the great meeting. It seems to get better and better every year. All right, so I'm going to be talking about the calcified SFA and how to tame it, atherectomy devices, specialty balloons, how and where I use them. So this is a famous slide that was making rounds a couple of years back of the Suez Canal. So the reason it's important is because that's exactly how calcium behaves in the vessels, especially if for all the panel who's sitting here, they can tell you that calcium is the bane of our existence as endovascular interventionalists. So why is that so? So the problem with the calcium is that it makes managing any PAD extremely difficult, both acute and long-term endovascular outcomes based on all the trials. They are not only dependent upon the lesion length, but also upon the severity of calcium. And there's actually no good grading system for grading calcium in trials. And most of the contemporary trials have excluded severely calcified lesions. So, the reason we need to optimize and deal with calcium is so that we can improve the lumen diameter, which is related to patency, and we can improve the stent performance and improve drug delivery, and also within the constraints of the ISR, improve the ISR outcomes. It's fine, I can just use that one, it's okay. Okay, all right, thank you. Okay, all right, so what are the various types of atherectomy devices that are available to us? There's actually a gamut of them now. So laser is an atheroablative device, and the rest of them are rotational. The last three devices, Phoenix, Jetstream, and Rotarex, are rotational and aspirational systems. So I'll talk about each of these individually. So firstly, CSI. So CSI, as you guys know from the coronary experience as well, it's the same 360-degree differential sanding away of the calcium, which leverages basically the centrifugal forces, and it facilitates, that way it facilitates the ablation of calcium. So essentially, what you use for what I personally use for this, which is off-label use of, I use a wiper wire, but sorry, this keeps. Okay, sorry, it has a mind of its own, sorry, my slides. So I use a wiper wire with a NAV6 system, but make sure when you do that, you use a peripherally equipped wiper wire, which is basically the 300 centimeter wire with a 014 wire with a 017 tip. So this is to prevent the complications of distal embolization. Okay, so then we have a myriad of devices available to us, starting from the 125 microburr to a 20 solid burr. So below the knee, you would use smaller burr sizes. In the infrainguinal area, in the fempop regions, you would use the bigger burr. Most of the times, I stay within 1.5 to 175 burr. Sometimes for the 20 burrs, you might need although it's compatible with the 6-French system, sometimes it's difficult for it to go over the iliac bifurcation, so you might need to use a bigger French system. So this is one of my cases where essentially, SFA CTO crossed to integrate and eventually did a 20 solid burr and then aligned it with Supera. This is another example below the knee. So again, laser. So now laser is interesting, and I use it specifically. Obviously it has an indication for ISR, but I also have started using it more and more in the calcified lesions. So again, it has a dual mechanism of action. It uses the sonic wave as well as the vapor bubbles, and essentially these are the sizes of the laser. So 0.9 to 2.0. So up to 2.0, you can use a 6-French system. Anything beyond that, you would need a 7 or an 8-French system. Another example, another one of my cases where it was a flush occluded SFA and crossed it again, integrate and laser, and then did a Stellarex and Alluvia, and essentially got a great result. Again, now one more thing in our armamentarium is the directional atherectomy system, which basically is unique in the sense that we are able to direct the the blades in a way so that we can deal with concentric calcium and popcorn calcium. So what it's a relatively easy to use device, and it has a drive shaft on the cutter blades that basically, like I said, could be used whose direction can be changed depending upon where the calcium is sitting. So again, most of the times what I use in my practice is the Hawk 1 system, and and it's very compatible with the 6 or 7 French. So most of the times in an SFA, I would use a Hawk M, and if I have to use it in big SFAs or in CFAs, then I use a Hawk S or LX. So the Hawk S sometimes we use when you don't have much room, and because it has a shorter nose cone for whatever reason. If you're close to an occlusion or whatnot, then it'll give you the ability to use it even with a shorter nose cone. Again, one of my cases, you see this chunk of calcium here in the middle. So I did few runs of Hawk M, and got a great result. And the more important thing, however, is that most of the times I use directional atherectomy. I use 90% of the times with a filter. So now the next 3 devices essentially are basically rotational systems that also have some aspirational capacity. So the Rotor-X is essentially a rotational excisional atherectomy system. So what it does is that it has its indication is both for thrombus and for calcified plaque. So it has an active aspiration, which it does through these windows that you can see over there. Sorry, through these windows, and essentially it has 2 types of setups. So essentially, it's 018 compatible, but off-label can be used with an 014 wire. So if you're planning to use a filter, so you can use either with a bare wire, or you can use it with a spider filter. So, and it has, depending upon the vessel diameter, if you're tackling smaller vessels, it's 6 French compatible. If you're doing bigger vessels, you can go all the way up to, from 5 to 8 millimeters, but you need an 8 French device. And essentially has, it goes up to about 40 to 60 RPMs, depending upon the device. And it has an active aspiration at the rate of 45 in the smaller system and a 75 in the bigger system. So it's just basically showing its mechanism of action. It has this modified bevel tip and a rotational abrading vortex. So essentially, the outside is it's a moving sheath, and the inside are the blades which are fixed, and therefore, it creates this suction force which ablates as well as helps to remove the plaque. Therefore, in theory, preventing dysembolization. Again, something similar to this, but less complicated nonetheless is the Phoenix atherectomy device, which basically does somewhat similar things. It cuts, it captures, and it clears. However, the difference being is that it has these Archimedes screws that they basically create sort of a passive rather than an active suction. And again, it's 014 compatible. And most of these are 6 French compatible devices, except if you use the 2.4 one, which is a 7 French compatible device. And the other difference with the 2.4 device is that the 7 French compatible device is that it has a deflectable tip. Therefore, it kind of overlaps with the directional atherectomy system. And then again, kind of similar to these last 2 devices is the Jetstream atherectomy, which is, I think, has been on the block a little bit more than the other 2 ones. So essentially, it is also a front-cutting rotational aspirational atherectomy system. So essentially, it does the same thing. However, the difference being is that it requires always a 7 French system, and it's 014 compatible, and essentially does the same things. And what I would say about this is that every time I have used it, I would recommend using a filter with it all the time. And I think any atherectomy topic or discussion is incomplete without IVL. Everybody would tell you that it has significantly changed our practice, the use of IVL. We are able to almost get stent-like outcomes. I tend to use it in conjunction with the other atherectomy devices, but standalone also, at least for moderate calcium, I think is pretty good. So what it is that, as you guys know, it's basically just miniaturized and arrayed lithotripsy emitters that are located on a balloon, and essentially delivers the same lithotripsy which we used to break kidney stones with. Now it delivers it intravascularly. Again, all of these devices, except for the 6, 5, and 7.0, which we use mostly for the iliacs and maybe bigger SFAs, they are 6 French compatible, and essentially atraumatic, provide excellent outcome, almost stent-like results, and now also in the iliacs, and I think in the fempop space, are also billable as atherectomy, so which is a great thing. So you can tell your hospital administrators that. So I think that'll be it for me. Thank you.